Hello everyone and welcome to Rad Chat Live at UKIO. This is number 13 of our Podbox experience. We've got a lovely guest here. Sorry, my name is Naman Jorkanson.
I'm Jane McNamara.
It's great to have you all back for another day with us. Please would you introduce yourself?
Yeah, so my name is Andrew England. I'm a senior lecturer from University College Cork in Ireland, diagnostic radiographer by background, and been to UKIO many times, but only really recently started back last year, and absolutely amazing event. So happy with how it's going.
Brilliant. So tell us, why did you choose to become a diagnostic radiographer? Tell us a little bit about your kind of career pathway.
Yeah, I was always interested in science. I think, when you think about being at high school and college, they were my strongest subjects. So I kind of thought I need a career with a science background. I was doing a physics A-level, a physics course, and there was an opportunity to go and visit the local radiology department, see the CT scanners, and it was a little bit then, actually there is people that use this equipment all of the time, and I think I'd always kind of liked the helping role, like healthcare and, maybe giving something back. So felt a bit of a harmony really between the technology, I think when I grew up, anything with a plug on it, we were always desperate to get hold of, but also that kind of patient side, when you've got a real privilege to help people, sometimes when they're at the lowest, where it's like potentially it's the worst day of the year for them, and you can just give a little bit, and hopefully they maybe they go away feeling actually that person made it a little bit better. So it was just that harmony with definitely with the technology, and for me that's grown. I guess we've got more kind of digital and technological in radiography as years have gone on, and less. So yeah, I absolutely love it.
What's your favourite bit of technology that you've ever worked with?
Well, I think it was multi-slice CT. I think there was that was for me a big gear change between the extra kind of examinations that we could do, the level of detail that we could see, and again, there was more post-processing and, more thinking around, contrast timing. So I was in a role where we got a 4-slice scanner back, I think it was about 2001, so I sound like I'm going back, in many years. And I remember being, not many places had a multi-slice scanner, and like first to train and sort of develop the protocols, and that was I absolutely look back and think if I could go back to that time and relive those couple of years again, that'd be that was a really I really enjoyed that part of my clinical career.
So tell me a little bit, how did you get into academia?
So I think when I did my dissertation, so I trained just a couple of miles from here at the University of Liverpool, and we did like the traditional sort of dissertation. There was a variety of options, but I ended up doing a clinical study where we were looking to see whether we could do a very quick MRI scan and replace that for lumbar spine X-rays in low back pain. And from that, I kind of thought we were going to try and publish, and I got a bit of a buzz in that, you could be the first person to find something new, like we could have found that's the, imagine now everyone was, instead of having X-rays, you were just having that, very quick MR sequence. So when I started my first job, when I graduated, I think they asked, where do you see yourself in 5 years? What are your career ambitions? I said I want to do research, and I suppose it kind of stayed with me a little bit, just that, kind of sort of working independently, thinking about methods. And there was a research job at the hospital, but it was only funded for a short period of time. So I applied and got it, and it was just literally, but this is brilliant, but it's going to end. And a job came in academia where at the time there was a third research time. So I thought that gave me the opportunity to keep doing what I love, but protect myself as well, so that hopefully you're not going to get drawn into maybe another clinical list because the department was short. So it was really out of the drive to keep researching that I went into academia, and been there ever since.
When you said quick MRI scan, how quick are we talking?
Then
most MRI scans I've had are not quick.
Yeah, so it was whether we could just do one sequence, one sagittal sequence, just to see things like if there was bulging discs and really just for those group of patients that, say that, really they've had, up and down with cases of low back pain, and you do an x-ray and maybe it looks normal, or there's some degeneration, but you don't really know, is it causing the pain. So at the time, I think it was really getting down to about 7 minutes. Now, probably people, your listeners, are probably thinking, well, with 25 years on, maybe a lot better anyway. We don't need those limited sequences. The scanners are much better. We have AI. But at the time, I think, MR was notorious that you'd only scan a small number of patients each day because of the scan time. So if you could essentially reduce that, could you do less sequences? And I know we often talk about doing less projections in radiography, and it's always a worry, then do you miss something, and does it sort of bite you downstream? So I suppose that was my first experience of MRI, and then I've not really been in that area since, apart from some of my work I do with the European Federation of Radiographers. We're looking at MR safety training, and I just did a podcast at the weekend on the MR safety landscape and how we can, I suppose, address training needs. So it was a bit weird, started with MRI, big gap in between with no MRI, and then maybe coming back to a little bit, I wouldn't say at the end of my career, hopefully I've got a good few years left, maybe mid-career is the better one.
So in terms of kind of your experiences in academia, what do you think are the kind of generalised themes that are going to revolutionise radiography in the next few years?
I think we've got to be look at efficiency. I think there are more patients. We've got an ageing population. Rises in chronic disease, and I guess more treatments available. With more treatments, there may be greater need for imaging. So I think we've got to be smarter with what we've got. In that we're not really going to get a massive. There's no kind of sort of magic wand that we're going to get another 2,000 radiographers instantly, or another 100 CT scanners or MR scanners. So I think we've got to look at how we become more efficient, but not losing the patient care side. That's often, a bit of a worry, that you think, if we could do that CT scan quicker, but there's still a patient there and they all have different needs. Some need, a lot more explanation and discussion. Some people are happy just to almost go in, lie down, and thank you, I'm off. So definitely efficiency, more individualised care. That I think as a population, we want we want the right care for us in the right way, not kind of this is the way we do it, and that doesn't really fit you. We're really sorry about that. AI will be, obviously enormous, and I think that there's some gaps in there that we need as educators to think about how we fulfil. And we're a lot more digital. One of the things that somebody, I think on one of the tele kind of health providers was saying, we don't really teach that. Yeah. We don't really talk about, transfer of images, reviewing images remotely, and all of those kind of things that brings. So there does need to be a bit of a change. I think, often we're very responsive that there's a need to change the training because of something in the past. Whereas I think we need to try and future-proof it. What are the training needs looking forward? And I think some of these digital skills, we're doing a podcast now where actually, those are skills the radiographers may need in terms of how they, how they advertise their departments, how they, engage with their patients. And I think we do need to be creative. That, I keep remembering, and I'm sure it still happens, that when we used to do barium enema examinations, you sent the patient kind of an instruction leaflet, and it's been photocopied and photocopied and photocopied, and you can imagine the quality wasn't necessarily as high as it could be. And then you read it, and there was bits of people who, if they had diabetes, and there was, and some people think maybe I don't know whether I've got that or not, and almost like information, and when you read it written very kind of technical, and we've spent so much time trying to sort of unpedal that, but actually, things like podcasts, listening to things rather than reading. There was a great example in the European Society of Radiology. They produced posters on patient, examinations, like a CT scan, but they were wordless. They were just based on graphics, so you don't have to worry about literacy, you don't have to worry about language. And I thought, such a good idea. Why have we not come up with that idea before, that you then don't have to translate it, 12 times. You don't have to worry that if you're in an area where literacy isn't great, we've got to make some changes because they're not going to understand what you mean by contrast, or when we use some of the MR terms like what's a coil. So yeah, I think there's lots that we need to do, but I think rather than be reactive, we almost need to look a little bit more in the future and try and build those in.
Amazing. Well, thank you so much for joining us on the podcast, and hopefully we'll get you on for a longer episode all about MR safety once it's all written.
Yeah, absolutely. I'd be delighted. Thank you so much.
You.